Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Asaf Bitton from Ariadne Labs about taking care of ourselves, each other, and our system. Let's get started. Gosh, Dr. Dan, it is good to see you. I am live from North Carolina.
Right, and I'm live from the beach in Virginia, so it's none of us are at home today.
Oh, that is great. And Dr. Bitton, welcome. It's so nice to meet you.
Nice to meet you both. I guess I'm live from Boston, Massachusetts.
Here we go. Dr. Bitton, you've spoken so much about, just policy and practice, and all throughout it all, you're a real life primary care doctor.
I was just seeing patients as of a couple hours ago. Absolutely.
So if you have a resident, many of our listeners are residents and students, people who are geeky about primary care or value-based care. So if you had a resident who's just finishing up training and he's walking up to you, he's saying, hey, I want to build a career in primary care that doesn't break me or burn me out, what would you tell them?
I would say that don't believe the misplaced hype that, that primary care is washed up or that primary care is too hard to do. It has its challenges like any worthwhile endeavor, but it is a profession that is a privilege. It's a gift to be in relationship with people, with communities over time, to take care of generations of patients, to really help to walk with people to figure out what matters most in their lives and their health journeys and how you can be of service to them. I can't think of many greater things to do. So yes, there are challenges, and I'm happy to talk about the challenges, but I'm also pretty bullish about the opportunities, both career-wise, but also at the nexus between how we are coming to understand the value of primary care, the opportunities with thoughtful use of technology in and around primary care, and with the ability of teams to not just take care of populations, but to augment, I think, the most beautiful part of primary care, which is that relationship between the individual clinician and the patient.
Yeah, that we've seen so much of that go away with all the relationships. The doctor-doctor relationship, we talk about that a lot I miss so much the doctor lounge and just curbsiding someone. And you in general, it was very rare where you'd be like, no, you're completely off. If anything, would have us focus a little bit more or maybe widen the system has been built in such a way that like all the procedures are valued and the relationships, which is what makes primary care work. It's not, I just don't see that outside in the billing model.
Yeah, well, I think, there's a historical accident to that we can talk about. And there's also, I think, a communal cognitive heuristic or a bias that people inside of medicine and outside of medicine have, this idea between hard and soft skills, this differentiation between a technical procedure and a really thoughtful conversation. There's a prioritization of the former and a strange deprioritization of the latter, even though I would argue, and I think that the cognitive data would be there, that it's actually more challenging and takes as much or more skill to have a relational, thoughtful, diagnostic, and therapeutic conversation around not just a description of what a person may have, but a pathway in partnership to build change with them around a set of decisions in their lives. This is really high-level cognitive stuff. This is stuff that AI is going to augment but not replace anytime soon. And if someone, and every once in a while we get med students and others who come by and say, well, all you do is sort of talk to patients. And I say, I can train you or have you have someone else trained in an endoscopy, a robot-assisted surgery, remove this, zap this, map that. But it's going to take you years to have a really good conversation about an undifferentiated diagnosis or a method into a behavior change that might actually work to meet that person where she is. And that's the beauty, the challenge, and actually our challenge as people who care about primary care, to help others understand the value and then put money and other resources behind that.
Say, like, even the public, as we travel summer vacation with the kids and we're meeting people in different parts of the country, and even the public's general mindset, like now there's a desire to move more, hey, what can I do in my life, rather than, for whatever reason, rather than going to the pharmaceuticals. Like I remember vividly, it was in the 90s, especially up until the 90s, it was, if the doctor gave you a prescription, there wasn't an argument or a fight about it. The doctor's giving you a medicine, you take the medicine. But now there's questions over basic treatments, even over-the-counter treatments, vaccines. I mean, just conversations that I remember early on in residency wasn't even an issue, but now we're having more of these types of conversations. So I feel like the public is ready too to kind of view primary care in a different way.
Yeah, and that can cut both ways. If I were to sort of take a step back and I agree with what you're saying, it's not just pace. And it's not just that we're impatient. I mean, that goes without saying. It's that, and I think we borrowed this from sociology there, and actually some writers, Tressie McAdam has written great stuff about this. We in the US over the last particularly 10, 20 years, we want to have mainly thin, quick conversations about thick, complex issues. Thin conversations are a quick judgment, a quick heuristic, a quick, I'm on this side, you're on that side, or we both agree, nothing else to talk about. But many of the issues, especially in primary care, that we deal with about sort of what are your core goals and values in the litany of the things that you are facing, what's important today, what's important in your family or your community sphere, how do we prioritize, how are we going to make a small change in small changes for a big problem. Those don't lend themselves to thin conversations or to thin zaps or quick hits or quick, hot takes. And I think that there's the promise and the peril for primary care. The peril is that we are a slow, kind of tortoise, thick conversations, building relationships over time, and in a moment where that's maybe not in vogue. But if you want to build in the trust, the way to help a person who's vaccine hesitant understand where and delve into their hesitancy and then kind of meet them where they are and help them build towards something that is good for their health and good for their community. There's no quick hit for that. There's no TikTok dance we can do together. There is a relationship we can build. So that's ultimately, to me, what the promise of primary care is. I actually think that as things get sped up and, there are only so many things that can be done in a thin way, people actually do crave relationships and they do crave a trusted advisor walking side by side, not telling them what to do, but at least respecting who they are. And then when asked, giving their opinion.
But don't you think it takes time to develop those relationships? And when you have administrators trying to drive volumes in clinic, not necessarily concerned about the continuity, every time you start over with a new patient, every time you're seeing a patient you've never seen before, you're sort of starting at ground zero and building that relationship, which is interesting. I think I saw it on one of your presentations you had done before, and I think you were talking about system issues, but I think it would probably fit with relationships as well, is that we often overestimate how much change can happen quickly, but underestimate how much change can happen over a longer period of time. Is that your feeling? I mean, I'm wondering about that both in the doctor-patient relationship, but also in the U.S. healthcare system.
Yeah, well, that's a quote from Bill Gates, who said that, we underestimate, and it's not his computer side of Bill Gates, but his, philanthropy side. And, in my other hat, in my other life, actually, where I'm here, when I'm not seeing patients, I run a public health implementation lab called Ariadne Labs and do a lot of work with the Gates Foundation and others. And I'm only saying that because I heard this directly from him. And what he's referring to is in public health, we want those quick hits, just like we were talking about. But it's hard to change systems, and it's hard to change multi-causal, multifactorial things. And so we get impatient in 2 years when we haven't seen the changes that we thought we would see with these investments. But his point was that we overestimate what we can do in those 2 years, and he used 2, but then we underestimate what happens in 10. And I thinking about that with respect to primary care, because I'm not just a sort of, bullish advocate. I think we have to see things for what they are, and the challenges in continuity and the challenges in workforce. I mean, I think if we look back in the last 10, 15 years in American primary care, I think they both prove Gates right and wrong at the same time. So I would say we've probably overestimated how fast change would happen in the payment landscape and in the kind of appreciation of the value of primary care. I mean, people across healthcare will, shout to the mountaintops about importance of value-based care, moving away from a volume-based system. And the three of us know right here that for all those big talks and nice papers and nice conferences, that predominantly in the US, primary care is still a fee-for-service treadmill. And I have to say, I wouldn't have guessed that 10, 12 years ago. I thought it was, the evidence is so abundantly clear that that's corrosive for the goals and practice of primary care medicine that I would have thought, administrators, et cetera, would have seen that. But that hasn't happened. On the other hand, we were still arguing about whether we should measure aspects of quality and move to electronic health records. And there were still, fierce debates about that 10, 12 years ago. And that's kind of a settled issue, caveats withstanding about some of those challenges. So, I think both are true, right? Change happens. I guess what we could say is it happens maybe more stochastically or unpredictably than we wish it would.
But how do we train the future doctors? Because especially in the academic centers, they are maybe more tied to fee for service than some of the other models out there. I was in a meeting earlier today and talking with some of the doctors about the advanced primary care model coming out of CMS. And their feeling was they didn't feel comfortable about billing patients that they weren't seeing every month, and taking that population payment. So, these are good doctors. These are people that really care about their patients, and they want to be fair to the patients, and they're afraid they're going to be unfair to the patients by taking payments without providing a service. And that's sort of back to the fee for service model, right? And so how do we all learn about population health, where you actually do get paid for the patients that are in the group, whether or not they come in for care that day, that month, that week, whatever?
I think that there are two ways into that question, at least. The first part is, what do we know, Dr. Dan? What do we know, or what do we think we know, about the best ways to train modern residents and medical school graduates to not only become primary care clinicians, but to become primary care clinicians that live and work in the communities that they trained and serve in, and that don't just sort of jump into the workforce and then kind of bring their time down because it's essentially an unmanageable and undoable job. And the short answer is that we know that medical schools that are community focused, that are this part of this tranche of new medical schools, one in Virginia, a couple in Texas, that are sort of built with the kind of state health needs in their focus view, that have in some cases mandates on how many people actually go into which professions, or at least guardrails on goals, and that have primary care and community-based medicine sort of front and center from day one. Not like as an afterthought or not as, leftovers, but, the goal really is to train these teams and then add into that community-based residencies, especially in teaching health centers and FQHCs. People who train in those pathways, they stay in those communities. They stay in primary care. They see the team-based modalities that can work. Now, the question is, how can then we meet modern payment methods to give them the space to do the both individual and population work. And that is not a simple question, but that really starts with, as you were saying, having people see a wider mandate than just the person in front of them, than just the who walks in the clinic. I mean, really starting from the fundamentals of empanelment. You take care of X number of patients. You and your team are responsible for them at some level, even if they don't come in. Now, if they don't come in and you can't reach them after a given amount of time, obviously, we can't go track people down. But we should try a little bit and not just sort of assume that we only take care of, the 14 people in that day's given session. So, that requires both education, mindset, but also the jump into this move away from a unit based of a bill just for seeing the person in a room to we get paid to track and follow up with you and to meet your needs, whether or not they're in the clinic, and that it's okay to in the case of APCM, to bill with consent of the patient and have them do an appropriate cost share based on the rules of Medicare, because they're getting good services. They're getting services that are worth a couple of lattes or a couple of, cans of diet soda. If you break this down over a month, most people can afford it, and most people want to afford it if it's explained well to them.
Yeah, because so much of the work that we do in primary care is invisible work.
It's work that when it works, nothing happens. And what I mean by that, like if we're doing our job, our patients aren't having heart attacks, they're not going to the ER for substance abuse crises or asthma exacerbations. So how do you show the value of a negative? This is a profoundly challenging thing because the surgeons, it's easier for them. A patient with an abscess, a lesion, a tumor, excision, put it together, don't mess it up, use a surgical checklist, rinse, wash, repeat. I know it's more complicated than that, but they have a kind of more clear logic line to getting a certain amount of payment, where we're saying, Dr. Dan, Dr. Faisel, pay you and your clinics a certain amount of money to control a risk factor like blood pressure such that heart attacks and strokes won't happen. And, this evidence of absence kind of stuff that is hard for payers, regulators, and purchasers to get their heads around. And yet, what could be more important?
And then we have the payers who are standing in between that, and they want to take that risk premium for patients getting better and continue to pay the fee for service to the providers doing the work.
Yeah, well, that's lazy on the payers' part, and I've said that publicly, and I say it privately to them too. And the reason I pounce on that is because they say that they want us to participate, us being in primary care, participate in value-based care, have the resources that we need essentially to make their accountable care or other value-based contracts work, and then they don't provide those resources sufficiently at the right level, at the right form, prospectively, and over a period of time, not just for a unit visit, and make sure, and this is maybe in the most insidious problem that I see, to make sure that the money, if you're in a health system, which 70% or more of primary care docs are in some sort of system or aggregate arrangement, to make sure that the money tracks its way through to get to its intended site. And then when you ask them, well, payers, we want the same thing. We want to help you avoid paying for heart attacks and untoward things. Why won't you make sure that the form, the level, and the flow of funds gets to primary care? And then they say, well, and you know what the answer is, Dr. Dan, most of the time? It's easier for our systems to just pay you guys in fee for service. So can we just do that? Or it's easier for our systems to just pay an aggregate to your health system that owns your practice. So can we just leave them the trouble of making sure that you get adequate fund flow? And the answer is no, you cannot, because it doesn't just happen by magic. So if the payers want to provide us with the resources which they should to do better and differently, they've got to do the work to make sure that those resources get to where they need to be, and not to line the administrators or the sort of, business parks of these large health systems and sort of get lost in some account.
Gosh, if we could only treat human beings the way we treat our vehicles. I last month I have a Kia Carnival. Our family vehicle is a Kia. I have 4 boys and 2 dogs. So we made the trip from Tampa to Lake Norman. It was in that Kia. And before making the trip, I took it to the dealership, and I took it with a mindset of the way I am with my vehicles and the way I would like to be with my own body and my own health. And so the car had a couple problems, but the time that the person at the service center took to have a visit with me and go over the problems, saying, hey, these are the things that we really need to address right now. And I went to him saying, look, I really don't know. I just, my car runs great. It's got all the features I want. I just need something safe. My concern are always just tires and brakes. And then he was telling me all these other things. But he spent about 20 some minutes with me alone because I had 3 problems. And it made me think about when I started at a community health center with 15-minute visits, which then changed to 20-minute visits. Now I'm at City Block that has 30-minute visits. So we've gotten to see the feeling of these different, short visits, all of them with the electronic health record after residency. But when I think about the time that it takes just to, even when you're in a rush to go in and out, right? I get it with the urgent care emergency room. People go in, their level of expectation is not to get into all the nitty gritty. But when you're going in with your health for a checkup, and the expectation is, we got to get to a level of chumminess. It takes time in that interaction. I mean, I've seen some doctors are great. The older doctors are just so good at getting chummy with a handshake. It's amazing how they can do it, like Jedis. But now, like as we're with the ambient AI and the time that it takes to get chummy, the time it takes to go through and have a conversation about 1 or 2 problems, maybe 3 problems, and then the time it takes to wrap up that conversation. I mean, with these short periods of times, I mean, as physicians now, we have to be extremely adept with these micro minutes, these minutes of the conversation. And for something that's supposed to be probably the most sacred relationship, it doesn't feel like that at all. I felt more intimate with the service manager at the car dealership than I think I ever have with the healthcare delivery system as a doctor. So how can we get back to more of this relationship-based style of care? Like think about our older faculty and attendings who are now in their 80s, right? Probably late 70s, early 80s now. They were still operating within the billing, the billing model, but I feel like they had much more relationship-based care than we do today with all the resources we have. So how can we get back to that?
Well, maybe a way into that is to look at what went right with your car dealership and maintenance appointment and what's changed or going wrong in our clinics, and then sort of try to bisect them. So if I hear you correctly, what you went into, and you had a set of needs, and there was, as there is in healthcare, there was information asymmetry. I mean, I'm not challenging that maybe you're a whiz with the mechanics of a car, but I'm just going to suggest, as with me, that car, I'm much more adept in human anatomy than I am with car mechanics. So that person made you feel seen and known, and bridged that information asymmetry, and did so in an organized, efficient enough, but not so overly efficient way that you felt demeaned or rushed or felt that you were made to feel stupid, and organized your visit around the core problem areas, made sure that there was agreement in those areas, and then with the fluidity around technical expertise, maybe even more than you wished, explained what the issues were, how you might approach them, got your buy-in to approach them, and you had a shared plan. I mean, this is what we try to teach our residents. So then what's not happening in our clinical environments? Well, first of all, you mentioned sort of the good old days. I don't know. I think maybe I'm going to make a guess that we all trained before work hours, and because I was on call for way too long, and I'm sure you guys were. So I'm not sure how good those old days were, but with respect to relationship-based medicine, one important thing is, okay, yes, people had more stable panels and were in practice longer, but I mean, 30, 40 years ago, the book of business for primary care was fundamentally different and actually smaller. The number of quality measures, preventive tests, chronic treatment guidelines, even just look at diabetes, how much diabetes care has just radically changed in 10 years. It's not just metformin, sulfonylurea, insulin. We could go on and on. So we have this massive expansion of knowledge. I mean, there are 70,000 ways the human body fails. Those are called diseases. And then there are about 19,000 ways that human beings, mainly in the last 50 years, have figured out how to address those failures. And it's our job in primary care to be generally facile enough in most of those thousands and thousands and make a match. And oh, by the way, make that match in a few minutes and manage that information asymmetry, show that we care, put an organized plan together, encourage someone to motivate themselves around behavior change, and then follow up. That's why it's hard, because it's the real crux and the nexus of all that we're trying to do. But on the other hand, this is where the core things that will keep people happy, healthy, and vital happen. This is where, chronic diseases will be diagnosed, managed, and treated. And this is where important new diagnosis will come up and be disclosed and dealt with. And so it's never been more important. It's just gotten a lot more complicated. And I guess I would lean on, just because I went on a little long with this, the need for really good communication, the need for teams, but teams that don't take over a relationship, they augment the ability of a clinician to have a core relationship with his or her patient. And then the thoughtful use of technology to take some useful shortcuts. And I would just say, ambient dictation is just one example. I've been using it about a year and a half, and it's not a panacea, and it still has, its hallucinations that you need to be very careful with. But I would tell you, I'm just thinking about my patients this morning, I'm able to focus in and be a lot more present. I used to type like this, type while I look at you. And my patients told me, especially the ones that really know me, they were saying, I know that even though you were looking at my face, that you were like 30% thinking about what you were typing, and you seem more present now that you can kind of just interact and deal with the note stuff later. So I think that's a window into how we can, think about in the next couple of years, we're going to have documentation clinical summary algorithms are going to say, hey, Dr. Faisel, Dr. Dan, here's a new patient, compress. Here are the 16 things you need to know about them. And by the way, here are the 6 gaps that are not immediately apparent that you need to deal with. I think that's going to make the practice of primary care actually a lot more fun and a lot more doable.
No, I agree with you. I think I've loved the ambient AI doing the notes, but very often then I have to go to another AI tool to plug in what's going on with them to say, hey, what am I missing here? What should I be thinking about? And, a lot of times it's just a memory jogger, but occasionally it is something really, really important that I hadn't thought about that will make a difference. And then when we work as teams, it works so well. I can remember not too long ago, I saw a young woman with a neck mass, and I was really afraid that she had Hodgkin's lymphoma, and sent her for a chest x-ray, and it looked like she had Hodgkin's lymphoma. And it was like a Friday afternoon, and a radiologist called me, and he said, we haven't met, but I bet you don't want this released to the patient over the electronic medical record. And I said, it'd be great if you couldn't do that. He said, if I put a hold on that, will you promise me that you will get in touch with her? And I said, absolutely. And then I was able to arrange a call with this young woman and her mother with her permission, and able to have that conversation before they read it over the weekend without somebody there to help them. That to me was, that was a very satisfying. I don't like telling somebody they have cancer, but I do like, I was thinking if it were me or my family member, I wouldn't want them reading it by themselves on a computer when they were alone. I would like for them to have the support system they need, both from the medical system and their family at the same time, to have that conversation. So I think if we can use the tools to help us make time for that relationship, that is huge, rather than just use those tools to say, well, you were able to see 14 patients a day before you had the ambient AI. Now you can see 22 patients a day, right? And so we're just going to increase the amount of out-of-visit work that you have to do.
Yeah, and what your poignant story to me highlights is the difference between knowledge and wisdom. I mean, the knowledge, if you're putting a premium on just spreading knowledge, then what happens is she gets her automated chest x-ray report with a mass that says likely, mediastinal widening and likely, Hodgkin's, and she's left there scared, alone, thinking the worst, going to Dr. Google. But what you're providing is really the wisdom. And I'm going to walk with you in this. We have a plan. Someone's behind you and beside you to do this. And by the way, it's not exactly what you read online. And I think that's what people want in primary care. And that's why it's not going to be so easy to just say, it's people who don't really think about what primary care does or don't know what it does that just sort of flippantly say, well, primary care is just simple, basic stuff. It'll be the first thing replaced by AI, or then they quote every week there's a study about, AI can beat a human in or can pass USMLE or et cetera. But here's the thing. What is the key thing that we do in primary care, maybe more than other specialties? So these studies are premised on the idea, if I give a computer a hard case with infinite information, and by the way, the computer can look up whatever it wants, can ask for whatever test it wants, and it's going to get positive predictive value better than most humans because it has nearly infinite attainable knowledge and we are just mere humans. But what are we after in primary care? We're looking for both positive predictive value, but we're a lot of the time looking for negative predictive value. Can I give you the sense that my clinical experience, aptitude, technical proficiency, and care for you as a person would suggest that rash or that lymph node is probably not cancer. And we are going to do what we need to do to prove that it is not. Now, AI can't yet do that. And it certainly can't do that with the relational empathic capacities that you all can. And so again, we need to refract, instead of saying AI good or bad, technology good or bad, we need to think about what are our core aptitudes and competencies that we're bringing forth. How do we help patients? We give them the diagnosis and after, or we help them understand that this isn't likely that, but if it is, come back next week and we'll figure it out together.
Oh, it's beautiful way of thinking about it and looking. We speak and meet with doctors, primary care doctors who are still in the fee-for-service model, living on very tight margins. I mean, we've had some doctors come on here talking about 2 to 3%, very tight margins, and they're so deep in that work of getting all the clicks and all. There's a lot of change. Look, in the last 6-9 months, amazing changes have happened, system-wide changes. But many of the doctors who are still in that grind still don't know. And at the last number I read about the number of us leaving, if it's out of 1 million doctors, less than 100,000 family doctors, 2 out of 5 are nearing retirement age. There are many doctors who are ready, they're burnt out and they're ready to walk away. If you had just one sentence to share with that doctor, what would you say to him or her?
Don't leave too soon. Don't give up yet. You went into primary care for a reason. I mean, let's just be real with each other. We all made an economically irrational decision. Okay. And there's either something profoundly wrong with us or something profoundly right with us. We can discuss that. But, this isn't a charity case. No, we all made a decision that there's something that is valent, that hits us in our core, we want to be of service. We love the relationships, et cetera, all the things we've been talking about. And we are willing to make trade-offs, right? And that's what we have important conversations with patients, facing serious illness. What are the trade-offs? What are your hopes and wishes? What are your fears? What are the trade-offs that you're willing to make for the things that matter most to you? We were willing to make those trade-offs. And then reality set in for that doctor who's facing the precipice of burnout and disillusionment. And without sugarcoating it, the question at hand, and everybody has to answer this for themselves, is, number one, is it just too much? And can I go no further? And, we need to make sure that our brethren and sistren are taking care of themselves. Too many have not. And we know what that means and the cost that has meant for them and their families. So we want, number one, we need people to take care of themselves. But number two, if they can, and then can they ask themselves a second question, which is, do you make the assumption correctly that what is will not change, that it cannot change, that it's just ossified? Or is it possible that the combination of the need for change, the fiscal impetus for change, the value of primary care, technological changes, and fundamental resetting of how we think about large parts of medicine are such that the practice environment isn't going to be the same in 3 or 5 years as it is now. Now, I'm willing to make the bet on the forward because I'm a hopeful person. Now, hope for me is a stance. It's not a prediction. I cannot give you a positive predictive value of my prediction. I can just say it's a stance that I, like in Bayesian statistics, I'm happy to change with new information. But if a person can ask themselves that question and they're not sure that things are going to stay the same, then they should stay in it because this is a noble and awesome profession. And I do think things are changing and that they can change for the better.
Oh my gosh, Dr. Bitton, thank you so much for taking the time to join us today. That was beautiful. That was beautiful. You give me a lot of hope. It is a messy, broken system, but it can be a beautiful one. And I do believe that it can actually change, especially after hearing you speak today. Thank you so much.
Thank you both for your time, and real pleasure to speak with you both. Thank you for what you do.
What are your thoughts on taking care of ourselves, each other, and our system? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.